All right, morning. I'm Dave Hardten from Minneapolis, and welcome. Hope you enjoy what we're going to talk about, and feel free to ask me questions as we go along. I'll give some information on CTAK, and then try to save some time for information. I'm going to go through kind of why I think it's a super helpful addition to what we're able to provide for our patients that have ectatic conditions like keratoconus or post-LASIK ectasia. Talk about some of my experience with it, my enthusiasm for it, and then also help to lay the guidelines for helping you get started with CTAK or escalating your use of CTAK and opportunities for the ability to help patients with these kind of conditions. And so first I'm going to give a little overview. What is it? Corneal tissue addition for keratoplasty. So basically this is an augmented procedure to strengthen, reshape thin, weak ectatic cornea. And so we use it for the treatment and management of keratoconus, which, as you know, is a progressive thinning condition of the cornea that is oftentimes underdiagnosed. And then our treatment 25 years ago was really wait till they got bad enough in a hard contact lens and they'd pop out and fall out, and then you'd eventually do a full thickness penetrating keratoplasty. And then about 15, 18 years ago, we started doing cross-linking to try to stop that progression, try to prevent that development of such significant ectasia that they needed a corneal transplant. And then there were other various different versions of augmentative or addition procedures, such as intacs or Ferrara rings outside the US, to be able to help reshape the cornea. And then obviously now we've moved into where there's even more and more options. Cross-linking's a very common thing, and then the corneal tissue addition keratoplasty is really taken off across the country and across the world. So the CTAK tissue provided by CorneaGen is a customized product, so it's specific to each individual patient. So part of what I'll do today is go through some of the basics of the planning component of it, and as you work through your patients, you'll kind of start to understand some of the basics of it. But they have a very customized, sophisticated algorithm or process for being able to do that, and their staff now has a lot of experience with this, and so they can kind of help you through anything you don't understand about the process, about the planning, so that you can really get good results with this customized product. And so it's not only the inlay, but also the plan. So where to put it, how far away from the center, how long, how thick. And again, we'll go through some of those as I talk a little bit more in detail. And the tissue is prepared with a femtosecond laser, and so the ability to control the width, the length, and the thickness of the tissue is extremely precise. So here you see it's less than a 25 micron or 0.25 micron or millimeter difference in the variance for things. And it's sterile, it's gamma radiated, and so it's comes in a fluid liquid. And the device is actually, or the tissue is a little bit stiffer than if you were to try to take a cornea from the eye bank and cut it yourself. And so I started out by doing hand cut, what we call anterior lamellar keratoplasty, regional segment, to kind of mimic what we do with other corneal tissues. And CARES was the name popularized outside the US mostly by Susan Jacob. But those tissues that were hand prepared were I still got a few patients I look and they're doing okay, but I look at them in the slit lamp and I think, oh, that's kind of ugly looking. That's all swirly and streamy, and they're really difficult to work with. Whereas this tissue, because it's already been cut, it's already been processed, is stiffer, easier to insert, and so it certainly is a much better product than trying to hand cut these yourself. Again, it's for treatment of keratoconus, and in this group of patients is really useful for it. And it basically initially, when the initial development was, they were thinking that, well, we'll go across the center of the visual axis, but really staying away from the central visual axis and supporting that bulgy area is really the key to this specific procedure. So I'll go through kind of the basics of the case. So part of it is marking where we want it on the center so that we can get the channels in the correct spot. And then the channels are, and again, this is part of the algorithm, then the channels are created with the femtosecond laser. And you'll see the entry site there. And then at the femtosecond laser, I briefly support or open the channels with the little insertion device, and then we'll slide the tissue in. I'll show you another video a little bit longer or later here. And what you're trying to do is get the tissue to reside about 15 degrees away from the incision, so that incision will flatten down, and so you don't need sutures with this. And then making sure that it's stretched out fully across the entire portion of the cornea. And I'll oftentimes do cross-linking that same day for the patient. And so when we're doing epithelium off, we'll take the epithelium off at that point and then do cross-linking later on. So again, we've got a variety of different processes that CorneaGen is providing. So they've got the tissue, the planning, and really their surgical support specialists or surgical product specialists are really good at understanding some of the nuances, and they've got experience with, over 500 cases now of CTAK, and so really they're well tuned in on it, and I think some of you, it sounds like have taken the wet lab before, but if not, then I'd encourage you to spend some time, because it's something where there are some nuances to it. Even though, if you compare it to the other surgical procedures that you do, you will definitely be able to provide this service for your patients. So let's talk about patient selection and planning. So when I counsel the patient, they're trying to understand what is this going to provide for them. And many of them are already in a scleral contact lens with their keratoconus, but many of them have trouble wearing their contact lens for a long period of time. They'd like to have some benefit out of spectacles for a longer time period during the day. So for example, when a patient says, "Well, I'm doing pretty well in my contact lens, why should I even consider this?" And I said, "Well, do you put it in, first thing when you get up in the morning, and then you take it out right before you go to bed at night?" And they said, "Well, no, I wear glasses." "How do you function in those glasses when you're, first thing in the morning or later on in the day?" And so this, I think, can provide an improved window of time period where they can function in spectacles or without correction, depending on their level of ectasia to start with. And it does that by, I talk about it like a girdle of the cornea, and so it's like a girdle or Spanx for the cornea, where it's pulling back on that bulgy area, improving the shape. And so it oftentimes will improve comfort in the scleral contact lenses, but also will get them a longer period of time during the course of the day to be able to provide vision with just spectacles or without correction, again, depending on their overall level of myopia. And so that's really helpful for the patient, because 8, 10, 15 years ago, when we were doing cross-linking only for the patients with keratoconus, they still were struggling quite a bit. And when all we had for support was Intacts, the Intacts don't do well with a scleral lens or a gas permeable lens post-operatively, whereas with CTAK, these patients do really well with their contact lenses. In fact, I let them go back into their old contact lens at about 3 to 4 weeks after the procedure, and then I tell them probably wait 4 to 6 months and then consider a refit. Or if they've never been fit in contact lenses, then I'll let them get fit at around 4 to 6 weeks after the procedure. So it's very compatible with still using glass or contact lenses for the patient. Obviously, even though there's a refractive impact, this is not like you're going to dial in like you would with LASIK if they were a -2 +1. You're not going to get 20/15 vision with that, but there still is an improvement in the refractive component of their disease with this specific procedure. So it's important to help them understand what those expectations should be when you're counseling and talking to the patient. So this kind of window of patients, or the group of patients, can be kind of as broad or narrow as you decide you want it. And what I would suggest is that at least initially you start with patients that are in this window because it's easier to help you understand what you're likely to be able to counsel that patient for. So moderate keratoconus. So not somebody that barely has keratoconus that functions pretty well in glasses. That's not the right kind of patient for it. And the patient that is 100 microns thick in the center, almost to have high drops and has a lot of scarring is not the ideal patient. They might do okay by supporting the tissue and getting them back into a contact lens, but they're not ideal because they've got all sorts of other challenges, and they're not going to do as well as this group of patients between 50 and 70, 75 diopters of maximum keratometry. The post-LASIK patient we'll talk a little bit about separately, but that's challenging. I would not pick those for your first 5 to 10 cases because you've got the secondary plane, and that you have to be really careful to not get into that secondary plane, and you want to set up a little bit more time for yourself when you do your first few cases, because I have had to resuture some LASIK flaps in that group of patients because it's just really hard to sometimes get down, over, through into the segment channel and not disrupt the previous LASIK flap. And so you have to just be really careful in that. So it's definitely not your first 5 to 10 patients. Moderate sized cones seem to do best. So those that are 5 millimeters or smaller in width, where you look at the topography. So those that are, keratoglobus like processes, there's really not enough room in the mid periphery to be able to create a channel at about 200 microns depth. So 200 microns depth is where we're placing these, which, if you've done Intacks before, you remember is more anterior, so you can get more refractive effect with that. You can do a broader range of patients than you might have been able to do with Intacks if you've done those in the past. But you still need, you don't want thinning way far in the periphery where it's hard to create the channels without that potential for separating off desmase or perforation with your channeling technique. And so that's why if you stay towards the center, that's really much more useful for that group of patients. And again, like I mentioned, if there's significant scarring in the central portion of the visual axis, even though you get an improvement in the shape, you'll sometimes displace how that scar sits, and so that can still be visually significant. Again, I do some patients that have some scarring, but those patients have a different expectation that I've tried to help outline for them when I'm going and talking about the procedure for that specific patient. So here are like patterns of ideal candidates for what that topography will look at. So we have kind of in our population in Minnesota, we have 2 different kind of formats of where the cones are. So for example, a lot of our East African, Middle Eastern patients have very aggressive central cones. And so in a central cone, basically the way it works, and that's kind of the picture up and to the left, the way it works is that by putting this tissue around the whole periphery, you're raising up that section, and you're kind of tenting or pulling taut that central component of it. Again, makes it easier to fit in a scleral contact lens because you don't have as much of that central steepening. And those tend to be very long segments based upon the planning. And so the longest you can really do, you need to leave 15 degrees, 10 to 15 degrees on either side of the incision. So for example, they're usually around 300 to 330 degrees of channel, basically, or the length of the channel. Our group of American or South American, Central American cones tend to have displaced infratemporal cones. And so there usually it's around 180 to 200 degree segment that's mostly supporting that infratemporal section of the cone, kind of like you see in most of the other patterns. So, and again, those that have pellucid or very far peripheral ones, I have done some patients, but again, these are ones where oftentimes their spectacle corrected acuity with high cylinder is not too bad. And it's, again, you have to be cognizant of the fact that you need 200 microns of tissue, or more than 200 microns, but you're going to put your tissue 200 microns depth in those areas. And so some of those patients with very far pellucid, like patterns where that limbal thinning is 200 microns at the, at the 11 millimeter optical zone right next to the limbus. Those are really not ideal candidates for that. But I do some patients that have a pellucid-like pattern, but they're not super thick in the periphery, where they probably really fall into that category that they really have low keratoconus rather than true pellucids. So, and again, here's just a depiction of the fact that if you're thin outside that 8 millimeter optical zone, then it's really not a good situation for this type of procedure. And unfortunately, that group of patients, it's tough because even keratoplasty is really hard for that group of patients because of the fact that you've got high risk of rejection, high risk of peripheral anterior synechii eye formation if you're doing a transplant. And so in some of those patients that have very high cylinder, actually I'll do a wedge resection in that group of patients if they're really struggling in a contact lens environment. So let's talk about the surgical plan. And so basically what you're going to do in your office, or what you're already doing in your office, is you will use the pentacam. You'll get a high quality image. The pupil registration is very critical or important for this group of patients. So you need a good image of the pupil, because in everybody, the pupil size or the pupil diameter or the pupil location is not the same, and so this can help to augment how you do with your procedure if you can plan appropriately for that. And so, and then then that pentacam is sent off in the raw data format to CorneaGen, and then they'll come back with a initial plan. And the way that works is they'll have an inner diameter, an outer diameter. They'll have a displacement, some displacement metrics from the center of the pupil. And so those displacement metrics come up visually, like this one here, for example, is pretty well centered on the pupil on this specific plan. You'll have an incision axis, like for example, this one here, it's centered, it's very long, so this is a central cone. I don't have the topography up here to show you, but that would be on a central cone. And then you'll have choices for the thickness of the inlay, and the thicker it is, the more flattening that you will get in with the cone. And so for example, if you have a patient that has a refractive error of about -1 +1 and they're 20/40, if you have too thick of a segment, then you're going to end up shifting them onto the hyperopic side if you flatten the cornea too much with this procedure. And so in that situation, you may need or desire or want a thinner tissue. And so as you go through learning about these cases, seeing how these cases work, and again, their support specialists are really good about helping talk you through kind of why they're suggesting this, why that algorithm, why the planning software comes up with that suggestion, and you can talk through it to try to understand it. And obviously, if you say, no, I want something different, that's your prerogative. But at least for the first 5 to 10 cases, I think I would just take what they're suggesting. So actually, I don't change mine very often, but occasionally I'll say, I see this patient, I look at them, and I think I'd like to switch it around a little bit. And obviously it's your patient, your eye, but their planning software is really robust, and it gives you good outcomes. So for example, in this one here, and you may not be able to read it back there, but the inner diameter of the channel creation will typically be 4 millimeters, and then sometimes in a larger pupil we'll go 4.5 millimeters, and then that outer portion is somewhat limited by your femtosecond laser capabilities, but you can go, you can displace it fairly far peripherally on most of the femtosecond lasers. So most of the channels have an inner diameter of 4 and an outer diameter of 8. This one here, for example, has 4.5 to 8 to try to avoid that central pupillary zone a little bit more with the tissue. And this here gives you options 1, 2, 3. So for example, this one here, the thickness of the option 1 is 350 microns, so the option 2 is 400, and then option 3 is 450. And the channel depth, like I said, is mostly 200 microns for primary cases, and then I actually use 300 microns if I'm doing a post-refractive ectasia case, again, which as I mentioned before, would not suggest for your first 5 to 10 cases. So, I'm going to go step by step through it. So, part of your initial process, after you've planned it, looked at it, counseled the patient, is going to be the centration of your femtosecond channel creation. And so, what are given to you are basically three numbers: the inferior, the infratemporal, and the temporal displacement from the center of the pupil. And I think those are helpful to mark. The challenge, though, is that even despite those specific marks, as you come down onto the cornea, the patient has little movements as you're coming down on to mark it. You've got parallax, so I prefer to do these underneath the excimer laser before I move them over to the femtosecond laser, so that way they have a fixation light that they can stare at and look at, and then I'll mark it. And then the other thing I use for comparison is basically looking at my mark and the picture to see how it relates to displacement from the center of the pupil. So for example, in this one up here, it's pretty well centered on the pupil. This one here is slightly decentered temporally in this left eye. So you see a little bit of the iris out here. So as you make your mark down there, then you're going to check it to see how that is. And when you get them under the femtosecond laser and you've docked, then you no longer have the specific relationship between the apex of the cornea and the iris. And so what you're looking at is your mark on the cornea. And if I make a bad mark, then I tell myself, I don't necessarily make another mark, because then you've got lots of ink on the cornea, but I make a mental note of my mark is too far temporal, it's too far nasal, and then I will purposely adjust that as I go to the femtosecond laser. This one here, for example, even in a left eye, it can be slightly infranasal instead, and then some of them are displaced inferiorly. So again, that the marking of the diameters is important, but your central mark is what you're going to be able to see at the femtosecond laser, and that's what's really guiding you to moving the channels to match what the template should be from that specific plan. So here again, you're marking corneal offsets, and then you're going to make your mark on the cornea, and then your femtosecond Myers or reticle is basically how you're going to center this as far as the markings. All right, so I'm going to show you. You're going to do a lot of easy cases in the eyes with tissue that's been, separated in an eye that's, has really slick tissue. But some of the more challenging ones are those that are fairly thick. And so my preference, I was talking probably too much at the beginning here. I'm going to go back. So my preference at the very beginning is to use the curved and the straight forceps, and then try to slide that tissue in. And what you're doing is you're pulling one of your forceps out, you're supporting the tissue so that it doesn't just pull it right back out again. And then once I have probably 2 to 3 millimeters of that tissue inserted, then my preference is to switch over to one of the advancement tools, and then basically slide that tissue along. And if they're really long, then what happens is it gets kind of bunched up. So then I stretch it out and then insert it more. And what you'll notice here is that on the initial incision part of it, I try to go ahead and get that part about 15 to 20 or 30 degrees away from the incision, and then stretch the tissue all the way around and then grab the other side. So this is more specific for the thick and long pieces of tissue, which are sometimes more challenging to insert. And so then the other challenge on thin tissue is it can easily fold. So again, I'm holding or inserting it to start with the curved forceps supporting that back layer. But then what you'll notice is this is a fairly thin section compared to the other one, and it can fold. And so you want to watch what happens as you fold, and then you're usually massaging that fold out on the cornea. So you'll see that right here it's kind of buckled a little bit. Right over here it's buckled a little bit. And so and it's kind of pinched together there. So the smoothing out of those tissues is very helpful. And then, because you want to be sure that it's stretched out to the full diameter or the full radius of that, and then that it ends up being 10 to 15 degrees away from your incision. And you want to resist the temptation to grab a hold of your incision with a tooth forceps, etc., because you can tear the incision. So I think of it more as I'm putting a tool in there to be able to slide underneath when I'm first inserting it, and then I try not to manipulate the incision again, because you can potentially tear up that incision. So I'm going to talk about outcomes, and there's some published data on CTAK, and so I'd encourage you to read those papers on published data. And so I'm going to present information that we presented last year as a poster and a paper here at the ASCRS meeting a year ago. And I'll present that. And these are patients where they had the CTAK procedure and cross-linking the same day. So it's a little bit different than the data that was in the initial process. And when you think about what you're going to do with your keratoconus patient, if they're older, haven't progressed, like for example, if they're 60 and you're trying to improve their shape to where they don't have to wear a scleral contact lens, and you're going to do their cataract surgery or that type of thing, I mean, those are reasonable patients. They probably don't need cross-linking, but most of our patients do need something to stop the progression additionally. And so the options are: do your cross-linking first, do your CTAK second, and then do your spectacle contact lens correction later, to do the CTAK first, the cross-linking second, and then rehabilitate them visually, or to do them all in the same day. And so my preference is to get all over with. So like the patients just say, get her done, and I'm going to work hard to do that. So in that, I'll actually do the channels, take them to the operating room, slide the tissue in. We use the operating room for the tissue mostly because it makes it easier from the pass-through reimbursement process within our surgical center, and then take them back out into the clinic area to do the cross-link. So it actually all happens on the same day. Now, many of you won't have a setup where clinic, ASC, all those things are capable at the same place. So I'm not sure it really matters. You just have to figure out the logistics of when you do that. But I do think that CTAK probably doesn't stop the progression of the other underlying components of keratoconus. And so I do think that having a plan to do both of those things is going to be helpful for the patient. So again, this is data on, and these are keratoconus only eyes. I'll show you the data on the ectasia eyes too. But so we had about 50 patients, average age 37. You can see that one of them was 77. And so again, this is a patient that is really struggling with their contact lenses, and can gain some improvement in spectacle correction. And so it's not likely to progress. But the average age was about 37. Kind of like is typical in keratoconus, probably a little bit more male to female. Uncorrected vision about 2140, best corrected vision 2040. So these are not your horribly bad best corrected on a Snellen scale, but if you look at their typical topographies, they've got a lot of displacement of the image or coma formation on their optics. So they're very significantly affected by that. And then their average spherical equivalent is about -2.5, 460 for thickness, and average Kmax was 61. And so here's what happened with their mean uncorrected visual acuity, and this is pre-op 1 month, and then at 6 months. So you see we went from an average of 2140 down to an average of 2066, and so again, it's not a refractive procedure. They're not going to be able to drive without their glasses like they would after LASIK or PRK, but significant improvements in the uncorrected distance vision, and similarly improvements in the best corrected vision and spectacles. But most of this is a quality improvement. They see reduction in that inferior ghosting, shadowing, and tailing. And you can see that it flattens the cornea on average. So the mean spherical equivalent, or the myopia, was reduced by about 1.1 diopters over that time period. And most of it happens in the first few days or so. I like to follow subtraction tomography for these patients, and because it's very visually impactful for the patients when I can show them how much that Spanx basically pulled back their bulgy cornea. And so for example, this is pre-op, this is post-op, and this here is the shape change on that subtraction tomography. And I use that also in my keratoconus patients that we're following over time. trying to determine are they worsening or progressing, and because you've done your CTAK, you've done your cross-linking, and then you're tracking them over time. So this is actually quite helpful for that part of it, because it's just super tough and confusing to try to compare dot by dot in your head how steep or flat this cornea is. And some of them will re-pick up their bad habits of rubbing or sleeping with their pressure in their eyes. So we constantly are reminding them about that. And so my process is still to recommend that they have annual topography or tomography, and most of them go back to their referring doctor for that. But in your practice, since you'll have the pentacam, you can follow that over time. This is the group of post-refractive ectasia group, and so this I'm pretty sure there were 11 eyes in this group here. And uncorrected visual acuity improved the post-refractive or the pink ones. So there's improvement, but it's not as dramatic, partly because they've already been pretty flattened in the center. So what you're doing is mostly trying to augment that central section where there's steepening, and so their Kmax does not change as much either as what you would have in the regular keratoconus group of patients. So what are the requirements? So you need either a Galilei or a pentacam, and you need to get the iris image system. So the pentacam has to have the iris photo capabilities on it. The lasers, we use the IFS, but the lasers that can work are the Zemer, the IFS, the Vigimax, LensX, and the FS200. So you see those, and again, they need to be able to create channels for the programs are developed originally for Intacs, and so these are ones that specifically cannot do that. But many of the patients or many of the surgeons will have like for example the LensX in your ASC, so you can actually do channels, insert the tissue, kind of all in the ASC. We use the LensR for our femtosecond laser, so we can't really do all of that right there within the in that specific ASC unit. The segments are 1950, so not 1999, but 1950 per custom segment. And then again, the support group that you get with CorneaGen or CTAK is really, really helpful from the standpoint of negotiating, suggesting, helping you develop that plan for your patients with the placement specs in relationship to the pupil, thickness, incision placement, length, all of those different designs. And so and we do our tissue use in the ASC, partly because for most of our insurers it's a pass-through as opposed to bundled into our facility fee. So you'll have to kind of look at the specifics of that. And we use the anterior lamellar keratoplasty code and the tissue code, and we use that same for the pro fee and also for the surgery facility fee.